Dr. Dilip Kumar. Before the lecture, I request Professor Abdul Chaudhary sir to say a few words regarding Dr. Dilip Kumar sir, and then we proceed. Wadud sir.
Assalamu alaikum and good evening to everybody. Actually, if you want to talk about Dr. Dilip Kumar, I have to say not a few words, but quite a few words. Dr. Dilip Kumar is Director of Cath lab Services and Chief Academic Coordinator at Medical Institute of Cardiac Sciences at Kolkata. He graduated from Banaras Hindu University, did his DM from IPGM at Kolkata. He's a Fellow of Royal College of Physicians of Glasgow, Fellow of Heart Rhythm Society USA, Fellow of Society for Cardiovascular Angiography and Intervention, Fellow of European Society of Cardiology, and Fellow of Indian College of Cardiology. He's an International Board of Heart Rhythm Examiner Certified Cardiac Device Specialist, and he possesses a professional experience of 20 years as a cardiologist. Dr. Dilip Kumar is not only a doer, he's also a preacher. He has a very rich experience in performing complex coronary and peripheral interventional procedures, and he has one of the largest experience in India in pacemaker and intracardiac electronic device implantation. And he has done the maximum number of conduction system pacing in Eastern India. He is the principal investigator in several trials in research work. He is also an excellent presenter with appreciated deliberations made in national and international forums of cardiology. And he's an accomplished researcher, and he has numerous publications in accomplished journals and articles. He has been awarded the most innovative cardiologist of West Bengal in 2019 by the Worldwide Achievers. He was also awarded the Healthcare Pioneer of East Award by the Times Group. As I was saying, he's not only a doer, he's also a preacher. Today, we are going to find out how good he is in presenting a complex thing in a very simple way. Dr. Dilip Kumar, the dais is yours.
Thank you. Thank you so much, sir. And
please, may I make one comment? Before starting our proceeding, I should have apologized further. Recently, one of our course content director, Professor Atar Ali, has lost his mother. We, as his colleague, as his friends, we in the study group and those whoever are associated with this group, pay our deepest condolences to Professor Atar Ali. Thank you, sir. Dr. Dilip, you can proceed now.
Thank you, sir, and deepest condolences to Dr. Atar Ali and his family. And let me pull out my slides.
Sound ta kom hocche. Sound is not good. Can you start sharing?
Yeah, my presentation is visible there?
Not yet.
We can see the screen.
Oh, is it visible now?
No slide in the screen, Dilip.
We can see the blank screen only, Dr. Dilip.
Okay. So, if
next one.
Once I'm clicking share screen, okay, I think it should come now. So,
yes.
Yeah, it's coming.
Yes, coming.
Now we can see.
So thanks to everyone and thanks for the kind words. And I can understand today is a day for a lot of sports activities, and we will keep it short today. So I'll be speaking on Assay conduction abnormalities, and sinus node dysfunction is responsible for 50% of all pacemaker procedures. this is a global statistics, but when it comes to Indian data, we have got kind of different kind of statistics. We get bifascial block and AV conduction anomalies in India more than sinus node dysfunction. But as per global standards, sinus node dysfunction is responsible for 50% of all pacemaker procedures. And tachybrady syndromes are the most frequently encountered form of sinus node dysfunction. So the sinus node, sinoatrial node is located laterally in the epicardial groove of the sulcus terminalis, and it's near the junction of the right atrium and the superior vena cava. And it's quite a superficial structure. When we look from within, you can appreciate it just above the crest of, cresta terminalis. And it contains the nodal cells and the transitional cells. And it's a spindle-shaped structure with a central body and a tapering ends. The head extends towards the interatrial groove and the tail extends towards the orifice of IVC. And it's not a very large structure, it's a tiny structure. It's only 10 to 20 millimeter long and 2 to 3 millimeter wide. So it's a very, very small structure, and it consists of densely packed specialized myocytes of no definite orientation. The nodal and transitional cells extend from the nodal body into the atrial myocardium, but actual cell-to-cell interaction is uncertain. So this is the whole list of etiologies of sinus node dysfunction and sinoatrial conduction defects, starting from reversible reasons to permanent reasons. So we have got drugs, we have got inflammatory disorders, which are reversible, trauma, it can also be reversible, sometimes ischemia. But majority of the time, the permanent one, which we commonly see, is a degenerative disorder, what we call sick sinus syndrome. And this is a kind of, not a particular one disease, it's a spectrum of disease. And then finally comes the familial disorders, and where conduction anomalies are there. Sometimes sinus node dysfunction can result from excessive vagal tone in individuals without intrinsic sinus node disease. So what we call the situation is hypervagotonia. And this is also seen in hypersensitive carotid sinus syndrome and neurocardiogenic syndrome. Sometimes well-trained athletes with increased vagal tone occasionally may require some deconditioning to help prevent symptomatic bradyarrhythmias. Surges in vagal tone also can occur during Valsalva, endotracheal intubation, vomiting, suctioning. Sometimes ICP is high, then there will be a bradycardia. Sometimes there will be a spinal shock, spinal cord, injury. It can also lead to bradycardia. So in these situations, there is a temporary measures needs to be taken, and sometimes theophylline and deriphyllin, they come handy in these situations. Episodes of syncope are often unheralded and can manifest in older patients as repeated falls. And the highest incidence of syncope, as we discussed earlier, the most notorious one is tachycardia and the tachybrady syndrome, which is the most kind of commonest seen and symptomatic kind of sinus node dysfunction. Occasionally, these patients can present with stroke, as these patients have a kind of atrial fibrillation, sick sinus syndrome, and paroxysmal AF leading to a thrombus formation and then thromboembolism. When it comes to natural history, the natural history of sinus node dysfunction can be variable, and it's a very, very slowly progressive disease. So someone comes with giddiness, a little blackout. If we're suspecting sinus node dysfunction, it's imperative to take time to evaluate properly, to take in confidence the patient and go for a proper recording of the the documentation of the bradycardia, be it Holter, be it loop, implantable loop devices. So we can take time, unlike AV conduction anomalies where you don't have much time. So this is a very slowly progressive disease, and the worst prognosis is associated with tachybrady syndrome, which is notorious. The incidence of new onset atrial fibrillation in patients with sinus node dysfunction is about 5.2% per year. And these patients also have new atrial tachyarrhythmias, and especially if these patients are given pacemakers, ventricular pacing can lead to enhanced chances of onset of AF. So these patients, only ventricular pacing can have a 22.3% chance of atrial fibrillation. And there is a data which says that every 1% increase in ventricular pacing is responsible for 1% increase in the chances of 1% increase in ventricular pacing in 24 hours. What I mean to say, the percentage of pacing can lead to a 1% increase in chance of atrial fibrillation onset in these patients. These patients also can have concomitant AV conduction system disease, AV conduction disease, which is although less common, 5 to 10%. And even if it is there, they are very slowly progressive. So this was the idea when a lot of atrial-based pacing was done. But as chances are there, development 2.7% per year, not very high, still a dual chamber pacemaker with a managed ventricular pacing and enhanced, intrinsic atrial pacing algorithms has to be encouraged, and dual chamber pacemakers are the standard of choice nowadays. Coming to chronotropic incompetence, this also is a reflection of a sinus node dysfunction, and it is seen in 20 to 60% of sinus node dysfunction patients. This is can be made out by the inability of a patient to achieve 80% of age predicted heart rate, and that age predicted heart rate is 220 minus 0.7 into age of the patient. So if the patient is unable to achieve 80% of this predicted heart rate, the highest heart rate, then it is a sign of sinus node dysfunction. Carotid sinus hypersensitivity is also one of the spectrum of sick sinus syndrome and sinus node dysfunction. And here we take a criteria of 3 seconds, and what we see, and here there is a increased vagal tone, and patients, usually the right carotid sinus, if we do testing and we do a massage for 5 seconds, these patients develop, they reproduce the sinus pauses during the test. A word about sinus arrhythmia. So sinus arrhythmia doesn't indicate sinus node dysfunction. This is very important to know. And sinus arrhythmia, these are of two varieties. One is respiratory sinus arrhythmia, and second is non-respiratory sinus arrhythmia. So the sinus rate increases with inspiration and decreases with expiration. And it's a P-wave morphology will remain normal in these patients. You can see a increase in heart rate with the same P morphology when the patient is inspiring, and with expiring, that patient is having a reduction in heart rate, and the PP intervals vary by more than 120 milliseconds. Then we call it a sinus arrhythmia. Non-respiratory sinus arrhythmia, these are phasic changes in sinus rate and are not related to the respiratory cycle. So these are a distinct entity and not related to a sinus node dysfunction. And a word about AV node. So as we see, AV node is a gatekeeper. Like howsoever maybe the rate of higher chambers, atria, sinus, during atrial flutter, atrial fibrillation, the AV node works as a gatekeeper. It's kind of accommodative conduction happens here. It's not like something which is a kind of plastic conduction. So AV node can allow, and it stretches and then it stops and the further conduction. Unlike the below AV node myocardium and the other cells, which are all or none, which follow all or none phenomenon. So these are like plastic. So either they will conduct or they will not conduct. But AV node is a kind of has got an elastic, what we call a tendency, and is accommodative. So these are the reasons of sinus node dysfunction as a pathophysiology. This can be a problem with impulse generation. The automaticity of the Assay node is lesser. Or second is the impulse transmission, like sinoatrial exit block is there. And sometimes when we talk about sinus node dysfunction, it implies both the problems are there in that patient. So this is the commonest problem, sinus node dysfunction. It's very difficult, which is contributing more. But as the evidence are getting gathered, the sinus automaticity versus sinoatrial exit block, most of these patients of tachybrady, they have both the components, and sinoatrial exit block, they also kind to be dominant in some of the patients. So this 3-second pause is a kind of a definition for sinus node dysfunction. It's not a criteria for going for a pacemaker if 3 seconds is there. So there is no pacemaker indication depending on a pause, how much duration the patient is having pause. This is not a criteria, but as a definition, if the patient has a heart rate of less than 50, sinus rate of less than 50, and daytime sinus rate, and sinus pause in daytime more than 3 seconds, which we call it a sinus node dysfunction. But obviously, it should not be mistreated as indication for pacemakers. Now coming to sinoatrial exit block, this first degree Assay exit block, we say that when there is an increased conduction time from sinus node into atrium, and this phenomenon can't be recognized in ECG. So here you can't see, because a sinus node depolarization is not reflected in ECG, rather atrial depolarization is reflected as P in ECG. So first degree Assay exit block, you can't, one can't interpret in ECG. Second degree, it's just like AV conduction, it's easy to know. Type 1 is progressive increase and drop, and type 2 is sudden drop. And third degree is no conduction into atrium. So you can appreciate here, there is a sinus impulse and a P wave followed by QRS. These are normal. But when it comes to the first degree Assay block, there is a sinus impulse, then there is a delayed P wave, but it is not reflected in ECG. You can't see a sinus impulse, so can't appreciate. The second degree Assay block, the Vankeback, what we call the type 1, there will be a progressive shortening of PP interval and there will be a drop. So there will be a kind of group beating. So this is called second degree type 1 Assay block, and type 2 is sudden drop of the impulse from P sinus to, there is no atrial depolarization. So you can appreciate here, the PP is getting shorter, 0.80, 0.72, and then finally a P, there's a missing P wave. And it will reflect on surface ECG as a kind of group beating. So a patient with a group beating, fixed PR and absent P wave, this is an indicator of Assay exit block type 1. So this I want to highlight. This is a kind of signature of this ECG signature ECG representation of this entity. There's a group beating with a fixed PR and absent P waves. What happens in second degree Assay exit block type 2? There will be a sudden missing P waves, and pause will be something like, it will be a multiple of PP intervals. So this is how you differentiate this as Assay exit block from a sinus pauses, because sinus pauses, the gap, the duration of the gap will not be into a multiple of PP interval. But in sinoatrial exit block type 2, it will be a block in a multiple intervals of PP intervals. So this is the catch point. If you encounter someone with a pause with no P waves, there are only two broad possibilities. It can be either a sinus pause or an exit block. And if this pause is in multiples of PP interval, we come to a conclusion that is an exit block. It's not a sinus pause. So, and here you see tachybrady syndrome. There you will not find any correlation. This is a sinus pause, and there will be a increased sinus firing, sinus rate. So suppose I ask this question, that what kind of problem is happening here? So there is a PP kind of sinus arrest here. So whether it is a sinus arrest or Assay block, how we can make it by measuring the gap PP, and if it is the multiple, it can be it is a multiplied factor of PP, then it is a Assay exit block, and if it is not, then it is a sinus arrest. So once these patients with a bradycardia or this kind of sinus pause ECG, patient coming with symptoms like giddiness and pre-syncope, syncope, diagnostic algorithm we all know. We start from ECG to exercise testing, sex testing, and give you a hint that this patient may have a sinus node dysfunction. Then drug like atropine, propranolol, we can remove the kind of influence of vagus and the sympathetic tone of this patient. And then we can make out what is the intrinsic sinus rate of this patient. And this can also give us a clue that whether this patient is having a sinus node dysfunction or not. And the commonest is Holter monitoring and long-term ECG recording, which majority of the time clinches the diagnosis. And EP study role, invasive role comes very late. And it's sometimes if you're in doubt or you're going for EP study for some other reasons, then I think this is indicated. So Holter and prolonged recording majority of the time clinches the diagnosis. Coming to the assessment of autonomic tone, we can use some drugs, and we can also use exercise like treadmill test. We can see for chronotropic incompetence. It can give us an idea that how is the intrinsic heart rate, how the chronotropic the patient is achieving a target heart rate or not, or the 80% of the maximum heart rate the patient can achieve or not. Sometimes we do a pharmacological denervation where we can use atropine of 0.03 milligram per kg and propranolol of 0.15 milligram per kg, and this will remove the pharmacological action of vagus and sympathetic tone, the basic sympathetic tone, what we call pharmacological denervation. And if the and then comes the intrinsic sinus rate. This is calculated by 117.2 minus 0.57 into age. So if you find that the intrinsic rate is far less than that, more than 20% less than that, then we consider this as this possible patient can be having a possible sinus node dysfunction. Now, finally coming to EP study. So EP study, we do two, majority of the labs, even if they are doing electric EP or not, even interventional cardiologists, they do EP study of SNRT and, corrected SNRT. And then there is advanced, what we call sinus node conduction time, which we will discuss. So SNRT is, we pace the atria from the right atrial, the high right atrium at cycle length lesser than the patient intrinsic sinus rate. And each time we have to pace for 30 to 60 seconds. So 30 seconds is enough. Duration of more than 15, usually we can, in the studies they have found that they corroborate with the positive findings, and they can distinguish. But a 30 to 60 second pacing, I think is recommended. We can go increase the pacing from maybe a shorter cycle length to a further shorter cycle length up to a 300 millisecond cycle length. And we can see that how the sinus node is recovering. So here we can appreciate the pacing. The S1 is 400 milliseconds, so 150 heart rate we are pacing. And once the pacing is stopped, we see the recovery of the sinus node and how the next intrinsic beat comes. So the SNRT here is 1625 millisecond, and the baseline sinus length, cycle length of the patient was 720 milliseconds. So a CSNRT of 905 milliseconds. So anything more than 525 tells us that this patient is having a significant sinus node dysfunction. So this is very easy to perform, but there are so many factors which can mislead the findings. So I will talk about the sensitivity and specificity. So this should not be used as basically a criteria for going for a pacemaker, number one. So symptoms should be the guiding factor. Sometimes once there is a recovery, there are secondary pauses are happening. And secondary pauses, they kind of tell us that a sinus Assay exit block component is, playing there. And there is a kind of a retrograde block, and Assay exit block is the predominant problem happening in these patients. These are the limitations of SNRT. There can be changes in autonomic tone due to the effects of pacing, changes in P-wave morphology suggesting a pacemaker shift. There can be sinoatrial entrance block. What I told you, these are the regions of secondary pauses sometimes, or secondary pauses can indicate sinus, automaticity problem as well, but majority of the times it indicates sinoatrial entrance block. So you get a secondary pauses more often than SNRT positive. And the hemodynamic effects of atrial pacing can also, sometimes affect the SNRT value. And in fact, direct sinus node recordings have demonstrated that the majority of these pauses are due to sinoatrial exit block, what I was referring earlier, rather than impaired automaticity. So this is a kind of a mixed problem where the automaticity as well as the Assay block, they are coming into play. Sinoatrial conduction time, basically we pace or give a premature atrial stimuli and at a particular intervals. So we can get 4 types of response basically. So zone 1 happens when we give it's around 20% shortest of cycle length if we are giving a atrial stimuli. And in these situations, mostly there is a collision and it doesn't affect the next sinus beat. Zone 2 is the what we see majority of the times where it kind of resets the sinus node, and then we can calculate the SSCT. And zone 3 is interpolation and zone 4 is re-entry. I will show you with the pictures. Here you can appreciate. This is the kind of zone 1 response where if we delivered an A2, it's going to be, collided with the sinus impulse and it's not going in and kind of resetting the sinus node and, affecting the sinus node. So A3 comes exactly at the same defined time. So there is no difference. This is the commonest response we see, and here you can appreciate A2 is going and resetting the sinus node. So here we can appreciate how we can make out SSCT is we calculate A1 plus A2 plus A2 to A3 and twice of A1, and if we subtract, then we get a value. So this is twice of SSCT. So if we divide it by 2, this is a sinoatrial conduction time, because the impulse has to, the paced impulse has to go to sinus node and come back again. So and it is also very it should be mindful that one should be mindful that where we are pacing, it has to be near the sinus node in the high right atrium. And this is the interpolation, and this is echo re-entry where the same sinus node impulse is getting mixed with that. Similarly, as we saw in sinus node refractor time, SSCT also has limitations, similar limitations. The assumption that entrance into and exit out of sinus node takes the same amount of time is not necessarily valid. And distance of the stimulation site from the sinus node is another source of error. So the farther you take the site from the sinus node, greater is the potential of overestimation of the SSCT. So it should be nearer to sinus node, high right atrium, near the SVC and RA junction. There is a problem with reproducibility of results. You see a SSCT which is normally around 75 to 125 milliseconds. Sometimes you notice it 75, sometimes you notice 110, 125. So reproducibility is an issue because of we know that the intrinsic vagal tone and the pacing response, everything alters there. Sinus arrhythmia can also create problem here. Shift in intrinsic pacemaker site can also mislead us. Depression of automaticity and sinus entrance block. So these all are limitations of SSCT, and that is why when we look at these two EP maneuvers, SNRT and SSCT, the sensitivity is 70% only. And specificity, of course, if you get it, SNRT of maybe 900, CSNRT of 900, it is specific of sinus node dysfunction. But still, it doesn't, enable and kind of give you an, indication for a pacemaker. Still, you have to look for symptoms. If the patient is having syncope, which can corroborate with this sinus pauses and this SNRT, only then we can go for a pacemaker implantation. So what I was discussing earlier, both the components play a role in majority of these patients. A spectrum of disease, it's not a particular isolated, very, very less often we see a particular a problem of, impulse formation or impulse conduction. So how to correlate this SNRT and SSCT with ECG abnormalities? Patients with symptomatic sinus bradycardia, they have longer SNRT and SSCT, both you can get. Patients with SA block, longer SSCT. Patients with tachybrady syndrome, again a longer SNRT, and you can get a longer SSCT in these patients as well. Or sometimes then you can get a kind of secondary pauses. So this is a flow chart by which we're showing how we evaluate these patients of sinus node dysfunction. Depending on the patient, is the symptom is the most driving factor and force here. Once the patient has the symptoms, look for reversible reasons. So if someone has a kind of was taking some beta blocker, some medicines, some of the reasons like some patient has a kind of inflammatory disorder where the sinus node can be depressed, patient has a trauma, patient has a kind of a increased ICT features. So if you rule out these things, and still patient is symptomatic and having a heart rate is less, then we can go for a Holter. And if we find that there is a pauses and the same pauses were correlated with the patient symptoms, then we can go ahead with the pacemaker. Or sometimes still there will be a diagnostic dilemma. Then finally we have to go for an EP study. So this is a recommendation for permanent pacing for chronic therapy, management of bradycardia attributable to sinus node dysfunction. So class 1 indication, patients who develop symptomatic sick sinus bradycardia. So it's a symptomatic, bradycardia, which is the driving force. It's not a, a finding of a 3 or 4 second pause on Holter or some, which can give us as a candidate of patient candidacy for a pacemaker. And second, two indications are patients with tachybrady syndrome and symptoms attributable to bradycardia. Permanent pacing is reasonable to increase heart rate and reduce symptoms attributable to hyperperfusion. In patients with symptomatic chronotropic incompetence, permanent pacing with rate responsive programming is reasonable to increase exertional heart rates and improve symptoms. And this is class 2B. It should not be taken as a class 2. It's 2B is in patients with symptoms that are likely attributable to sinus node dysfunction. Trial of oral theophylline may be considered. So this is not something which should be looking at. So finally, I will end my presentation with one question, which to the participants. Suppose we get a patient with atrial fibrillation, and he's having a kind of ECG of ventricular rate of 50, 55, 60, and he presents with giddiness, but no definite history of syncope. And his Holter reveals a ventricular pause up to 4 seconds in Holter. So what should be the treatment in these patients? Should we wait and watch? Should we go for another Holter, not to pace at this moment? Or are we going to jump and do a pacemaker to these patients as he's having a 4 second pause in Holter, patient with atrial fibrillation? It's not a sick sinus, although this is a common syndrome, but it's a pacemaker with patient with atrial fibrillation, chronic AF, persistent AF with giddiness, slow ventricular rate, and heart rate, and a pause of 4 seconds in Holter. Does it makes the candidacy of a pacemaker to this patient? So with this, I will end the presentation. If we can get a poll or can get some of the response from the audience or participants, and then we can discuss it, and we'll take it further, our discussion from there. Thank you so much for the patient hearing.
Thank you, sir. Thank you, sir, for your nice presentation. We will arrange the poll if possible. But before that, there is a question from a participant that up to in case of chronotropic incompetence, if a patient performs ETT, so up to which stage it's going to continue before saying that the patient has not achieved 80% of age predicted maximum heart rate?
Yeah, I think so. If the patient is unable to achieve 80%, only then we can say chronotropic incompetence, and patient ETT will be kind of non-confirmed. We can't make any conclusion from that stress test. It is important. And then this chronotropic incompetence will only tell us that this function may have sinus node dysfunction. So it doesn't give you any extra information. His ETT will be not contributory, non-conclusive, and it will just a kind of indicator that sinus node dysfunction is there. You can't make out any extra information from it.
Tushar?
Sir, poll, Ribhu, can you arrange poll for the question?
Thank you.
Ribhu, is it possible? I think there is some technical problem happening.
Dr. Dilip, one question is that you were saying in awake time, if the pause is more than 3 seconds, This suggests sinus node dysfunction. What about the pauses that we find at sleep time that we do not pay that much attention? How much will we accept as quite all right?
There is no such criteria of kind of sleeping time sinus pauses. There's no such criteria. So whatever we take into account, it has to be awake. And a 3-second pause is just an indicator of sinus node dysfunction. It doesn't give you an indicator and a candidacy for pacemaker implantation. When you talk about 3-second pause, there's a lot of misconception among physicians that, oh, 3-second pause there, let's go for pacemaker. This is absolutely not correct. And in carotid sinus, carotid sensitivity syndrome, we take 3-second pause while doing our test. So there it can, if the symptom is reproducible with that test, and we are getting a 3-second pause, then it is kind of contributory. But in sinus node dysfunction, in Holter, a 3-second pause doesn't mean anything. It gives you an indicator that sinus node dysfunction is there. Patient is symptomatic, and symptom is collaborated with this, pauses, then patient can go for a pacemaker.
That's the most important thing. In Holter, we have to corroborate the symptom with the timing of that particular pause. Otherwise, that pause doesn't have any significance. It's the symptom that is the most important thing.
And my idea was for this ECG, which question which I wanted to have a poll. Basically, we look for 3-second pause and 4-second pause. But for atrial fibrillation patients, if he's giddy, he's feeling giddy, then the pause criteria is 6 seconds. So it's not a 3-4 second pause. Especially in atrial fibrillation patient, slow ventricular rate, if a pause of more than 6 seconds is there, then it becomes a criteria of a pacemaker implantation.
Thank you very much. Dr. Dilip Kumar.
Yes, sir.
There is a differentiation between the sinus pause versus exit block. Is it only the academic interest, or does it have any clinical importance? That is the differentiation between the sinus pause and exit block.
It doesn't have any extra clinical importance. So basically, the spectrum of sinus node dysfunction can be overlapping SNRT, abnormal SNRT as well as abnormal SSCT. So, but for a kind of academic purpose, if we are getting a group beating with a normal PR, and the pauses are in multiples of PP interval, that indicates a sinoatrial exit block. And if the patient is symptomatic, they carry the same significance.
Sir, there is a common notion among the common physicians is that if the patient complains of syncope or pre-syncope with the sinus node dysfunction type features, the frequent advice is go for pacemaker. So how they should approach, or what should be the ideal advice?
Yeah, I think we discussed it, and a little while back also we had discussion. So a patient who is having a sinus bradycardia on ECG, and he is having a syncope, clear-cut history of syncope, and then we go for an Holter, we see a pause of maybe more than 3 seconds. More than 3 seconds to just stamp that this patient has sinus node dysfunction. Then we have also asked these patients whether the patient had a similar symptom happening at that time or not, or did he feel giddy during that time or not, number 2. And then we have to look at all reversible factors. Many of the times these patients will have a kind of a beta blocker, some other drugs which he is taking. Then we have to stop the medicines. We have to do the test later on. Or sometimes there is a other reversible reasons are there, some inflammatory myocarditis, pericarditis. There also we can see some sinus node depression. Sometimes patient of a ICU setup, if the patient is there, some bradycardia, sinus bradycardia is there, and you get a referral from a neurologist and neurosurgeon colleague that the patient heart rate is 30, what to do? So these are reversible reasons. So we have to remove rule out the reversible reasons. And if on Holter there is sinus pauses more than 3 seconds corresponding to the patient's symptoms, then we can go for or sometimes patient requires additional drugs which needs to be given. Like patient has a atrial fibrillation, to look at the heart rate, increasing heart rate, you have to give some beta blockers. So in these situations, we can, on the drugs, we can go for a pacemaker.
Dilip Kumar, when you see the group beating for academic interest, what are the differential diagnosis of group beating? Is it specific for the sinus node disease, And what is the ECG criteria? Is it necessary to see the P wave pause, that is the absence of the P wave for the group, defining the group beating? Can you clear the concept, group beating?
I think very important question. Group beating can happen in AV conduction anomalies, and group beating can happen in sinoatrial conduction anomalies as well. So in AV conduction anomalies, you will get a varying PR, okay, because there will Vankeback is happening and there is a group beating is happening. But when there is a sinoatrial exit block, which is leading to group beating, here the PR will be fixed.
Right.
And suddenly there will be there will be a pause in group beating, and this pause will be in multiples of PP interval. But
Right.
when AV conduction problem is there will be a varying PR interval and there will be a group beating. So this way you can differentiate. And obviously a AV conduction problem can be considered a little more severe, because the AV conduction problem, they progresses faster than sinus node dysfunction. So sinus node dysfunction progresses in 10 to 30 years. AV node conduction anomalies, conduction disorders progresses in less than 5 to 6 years time.
Thank you very much. Tushar, Chaudhary Hasan want to say. Chaudhary Hasan.
Yes, sir.
So I think one of the problem that we see is the pause during the night with the sleep apnea studies. And
yes, sir. That's the most important, one of the important aspects that seldom discussed in our part.
And I don't know what, I don't know, Rafiq Bhai is also here or not, but this is a problematic area because 6 seconds or what rule you follow. I tell you, it is very difficult to convince our EP guys here to put a pacemaker in those patients. They will not take, even if it is more than 6 seconds.
True, sir. I think you're very right, bang on target. There is no such criteria laid down in the guidelines. There is no such sleep apnea with a 6-second pause. There is no such recommendation. But definitely we know this fact that if there is a pause of 6 seconds, there will be a kind of hindrance and there will be deficiency in cerebral perfusion. And it can lead to hypoxic injuries, small hypoxic injuries, and later on it can become a bigger problem. So it's still a gray area, and I don't know how to deal with these patients. But if these very frequent pauses are there is no harm in going for a pacemaker. But this,
so our EP, we are doing it is, of course, we are giving the treatment for sleep apnea, and then also looking at baseline EKG, any association with left bundle or right bundle, left axis, first degree AV block, and then also, if possible, to do a chronotropic incompetence test if they can do exercise. All these we are doing, but we are doing, as you pointed out, Dr. Kumar, that trying to avoid a pacemaker in those patients.
And I think these are the we can, I think we can go for SNRTs, SCCTs, and with incompetence to gain a further evidence to go for a pacemaker.
Vadut sir, I just want to ask you a question. Is that how you advise us regarding the sleep test in case of sick sinus syndrome patients to avoid pacemaker? You have several cases. You have several cases where you did not put pacemaker and do the sleep study. Can you please share your experience, sir, regarding this issue?
Actually,
because it's a very problematic.
I have seen many patients who has been advised for pacemaker because there's big pause, not 3 seconds, 5 seconds, almost 6 seconds, some patient. But I see that the patient did not have any symptom. Why they have some change in the ECG baseline? That's why that particular physician has ordered that 24-hour Holter. And I asked him, do you snore? The patient is obese. Well, yes, his wife is saying that I cannot sleep with him. So go do the sleep study. Don't you worry. You are not going to be in a problem in a hurry. And there was severe obstruction. And when he started BiPAP, I advised him to do the Holter again after 3 months. It's quite all right. So the symptom, it's always the symptom which should be taken into account before deciding whether you are going to put a foreign body in the patient's body.
Can I make a comment?
Sir, of course, sir. Of course, sir.
Sure. It was a great lecture, and I'm happy to hear that you are fairly strict about putting pacemakers in. It's very important. Let's say I do a Holter on a patient who came for palpitation, and I find a daytime pause of 6 seconds. What do I do then? First thing I ask the patient, was he sleeping during the daytime? See, this patient never had syncope or pre-syncope. So we always try to make sure. Please remember, sleep apnea can also happen during daytime if the patient is sleeping. So that's important. The other part, that the difficult part happens is, as Hafiz mentioned, that we are very resistant to nighttime pause. I mean, I will tolerate pause 10, 15 seconds if it is asymptomatic. It becomes a problem when somebody comes with syncope. That's why the clinical scenario comes into play. I mean, all these tests, we have to clearly ask the patient how they are. And then the best case scenario will be if we can correlate symptom with the arrhythmia itself, the pause. Thank you.
Rubik sir. Hello, sir.
Yeah.
Sir, is there any situation when you give importance to the sleep time pause, or in all situations we should ignore the sleep time pause? Is there any situation when it is important, sir?
As Hafiz mentioned, you will have to convince us, really. Like one time I had a patient with a pause of 20 seconds, but I called the patient and she works at night and she had a syncope. That I put a pacemaker in. And that was a relatively young person. But I think that you have to, I mean, we see a lot of patients with nighttime pause. Somebody comes with dizziness and nighttime pauses. And dizziness is not a serious symptom. So in those patients, we always like to correlate symptom with arrhythmia, and we'll sometimes put a loop recorder in to see if they're having symptomatic bradycardia that is causing, if the pauses are causing any symptom. Thank you.
Sir, sometimes we find problem in atrial fibrillation patient, the ventricular response is very low. The patient is having heart rate around 40, 45. And the patient is having progressive cerebral loss, dementia progressing. The neurologist is suggesting that this patient will help with the money if you can improve the heart rate. What will be your decision in those cases? Dr. Dilip, your take on that?
Sir, I think it's not any criteria to go for a pacemaker in these patients. Number one, we have to document whether dementia is happening because of multiple thromboembolic episodes happening or not. In these patients, not a bradycardia which is responsible. Maybe these patients can have multiple thromboembolic episodes, small infarcts multiple times, and lead to progressive dementia. Or bradycardia leading to dementia is a very unlikely possibility. So if you get the pauses more than 6 seconds, sometimes daytime, this can be in atrial fibrillation, slow ventricular rate, it becomes a indication.
So Dr. Dilip Kumar, sorry, by the way.
Extended halter will be a better choice in here before deciding anything like that. Rafiq sir, your comment, please.
I totally agree. Dementia cannot be explained by heart rate. Fatigue can be. If somebody comes to me and says, look, the heart rate is low and the patient cannot do day-to-day activities, that's a different story. And in those cases, we can make a point that if we increase the heart rate, his activity level, but the dementia, I doubt very much that it is related to the bradycardia itself. Thank you.
Dilip Kumar. Hello, Dilip Kumar.
Yes, sir, I listen.
Sir, one more question. A patient of a 6 sinus syndrome, predominantly atrial fibrillation with slow ventricular rate, that is symptomatic bradycardia, narrow QRS, but ejection fraction is less than 40. He needs the pacemaker. What will be the mode of the pacemaker in this case?
Yeah. So,
Dr. Kumar, before you say anything, can I tell one thing to Dr. Rafiq Bhai? So, so Rafiq Bhai, dementia. So sometimes we miss simple things. Dementia with the bradycardia, and our patient had a TSH was like 23 or 29. So sometimes when you see a patient in the hospital, you need to look at whole thing. And Rafiq Bhai is right that of course dementia alone cannot explain. But when you look at the chart, there is no TSH. So we said, okay, let's do a TSH, and the TSH came high. So that solves the whole problem. Yeah.
Yes,
very
that's very true.
And then, hypothyroidism is a treatable cause of dementia. Remember that we need to remember the treatable cause of dementia. Not all dementia is equal.
Hafiz Bhai, do you have a presentation ready?
I have, yeah.
Uh,
But I'm a backup for Rafiq Bhai. Remember? Rafiq Bhai first.
No problem.
Rafiq sir, would you start?
Acha.
We will have some input from Dr. Dilip then.
Dilip was last question. Yes.
thoroughly asked. Patient with less than 40% ejection fraction with AF with slow ventricular rate. I think this patient will be having a demand of pacemaker for a more than 40% time. So it's always good to go for maybe a his bundle pacing in these patients, physiological pacing, or you can go for a CRT in these patients.
Thank you very much.
I have a comment on that. You see, the fact that somebody's ejection fraction is low does not mean they have impaired AV conduction. I mean, look at the price difference between a CRT pacemaker with a dual chamber pacemaker. So if the AV conduction is good, then you can choose to put a single atrial or even dual chamber pacemaker with prolonged AV delay. So that if you program the AV delay long, patient is not going to pace in the ventricle, it will not worsen the heart failure anymore. However, if there is AV conduction problem, then it becomes a different story. So you cannot make a blanket decision on those group of patients. Putting a CRT is a simple thing, but I always look at devices long term. What will happen after 10 years, 15 years? How many lead are you going to put in? So we have to be careful about that. Thank you.
Very right, sir. We discussed that the patient if require more than 40% of the time
40%.
pacing, I think then yeah, CRT or a physiological pacing will be a better option.
Yes.
But that 40% shall apply to the ventricular pacing, right?
The ventricle.
Yes. If there is, even after, absolutely right. Even after optimizing the AV delay, if there is ventricular pacing more than 40%, of course, this patient will develop worsening heart failure without a CRT pacing. And I think in Bangladeshi context, we are doing more and more left bundle pacing here, his bundle pacing. I think that is the technology that needs to be developed quickly, because then you get away with two leads and you can put a dual chamber pacemaker acting like a CRT pacemaker.
Thank you, sir.
Rafiq sir, are you going to show us some interesting ECGs?
No, it's Hafiz's day. I have to go to the airport.
All right.
Sorry.
Okay.
Hafiz Bhai, would you please start?
Next time.
Okay, so let me see whether I can get this, upload this.
Dr. Dilip, please stay with us.
Yes, sir. I will be there, sir.
Okay. So the EKG that I'm going to show today is actually some of the situations that we are having in Las Vegas now. Can you see my screen?
No, we can see
No,
you.
sir.
Okay.
Not yet.
Okay. You can see my screen now, right?
Yes.
Yes.
Okay, so let me see whether I can do this way.
All right.
EKG and beyond.
Very
Okay,
little.
can you see now?
Yes, we can see now. We see it now.
41-year-old male, can you see?
Yes, yes, exactly.
Okay, good. So 41-year-old male, let me, so this is like only from last Thursday, Friday, and we are still struggling with these patients. Found outside altered mental status, Glasgow Coma Scale 3. And then the reason we got involved because the emergency room physician, they call us. Okay. I am having trouble here. I cannot move. Oh my God. I don't know what happened.
Slide not changing.
Slide not changing, yeah. Let me upload again. So share. So actually, let me tell you that the EKG was called in for ST elevation MI. And what do you do in this situation? Can you see my slide now?
No, Hafiz bhai.
Yet not, sir.
Oh, okay. It's a disaster. Okay. Hello?
Yes, sir.
Oh, I'm still connected, right?
Yes, sir. We are connected, but your screen is not visible still yet.
Okay. So can you discuss something? Let me disconnect and come back.
Okay, okay.
Okay, sir. Sir, there is a frequently asked question. We frequently see the athletes or the athletes have bradycardia, simple sinus bradycardia. Sometimes it's too low. So how come this sinus bradycardia helps athlete to endure training? What is, sir? What is the mechanism in that?
Well, it's actually the efficiency of the heart. What you need, the heart has to work to provide adequate perfusion to all of the body. And if it can do with a fewer beats, why should it work more? Athlete's heart is a little bit more dilated, isn't it? Larger size, more powerful, can do work more efficiently. So they need to work a little bit leisurely. That's what he's doing.
Tushar, you can remember the Rofik sir slide. That is the teeny bird has got heart rate more than 200, but the elephant has heart got only 12.
Yes, sir. So that's why.
Can I make a comment? Can I
Yes,
make
sir.
a comment
Yes,
on this?
sir. We are waiting for your comment.
Okay, if you look at athlete heart versus hypertrophic cardiomyopathy, both gets left ventricular hypertrophy. The difference is in athlete heart, the heart is bigger. So they pump more blood in one time. Beyond the one time that had heart rate of 58.
Hello?
Hello, sir. We can't hear
I
you.
cannot hear.
Rofik, sir.
Yeah. Can you hear me now?
Yes, we
Yeah,
can
yeah,
hear,
yes, sir.
sir.
Yes. So as I was telling that the athlete hearts, they are dilated and hypertrophy. So they can pump more blood in one heartbeat than normal people. And that's how they compensate. And as I always mention, there is nothing called low heart rate. There is only called fast heart rate. Thank you.
Thank you.
Afita, we can see your slide beautifully now.
What is the cardiac output of an elephant? Heart rate times stroke volume. So
Well, Hafiz, blue whale's heart size is 180 kilograms. So then you can imagine how much blood it pumps. So basically it is bigger than our body.
So,
The heart
you know, it's a joke, but don't, oh man. Okay, so it's a joke, but don't take it literally. There is an argument that swimming is a good exercise, but the whales that they swim all day, but they don't reduce weight. So there are some controversies in medicine. No, there is no controversy. So Rohit bhai, so what, before you go, I wanted to bring this slide forward for you. But let me hear the unconscious patient, 41-year-old. And the ER is calling us because of the, of course, the ST elevation in the AVR, and then deep downsloping ST depression in the precordial leads. And also look at the lead 2, 3, maybe AVF more. So what do we do now? And this is Las Vegas.
This looks like left main disease.
Yeah. So say, I'm enjoying that Madhu is moving his head.
But
Yeah.
this ECG does not explain the unconsciousness. What was the reason?
Exactly. That's the point.
Exactly. Exactly.
That's the
Dr. That's the main thing. And the whole point hangs on that. Otherwise, you nicely pointed out that there should be. So this is a patient has a heat stroke. Las Vegas temperature running currently, if you are not following the temperature, from 111 to 115.
My God.
Okay. So, but I don't know, Rafiq bhai is here. So what about the rhythm? Because
Hafiz, I cannot see. I'm driving, so I cannot see the ECG.
Okay. So the Atar bhai, because Wadu picked up the ST elevation. That's what we care about. We don't, and we care about, and Rafiq bhai, forgive me for commenting this, because we, the interventionalists, we look at tachycardia or bradycardia. And then we looked at the ST elevation or not. And then we figure out, it's narrow complex or wide complex. So in my mind, this is narrow complex tachycardia and significant ST changes. Narrow complex, so probably AV nodal re-entry tach, maybe, because, but it is not like 150. So, and it is over like 170, 180. So we called it narrow complex tachycardia, most likely AV nodal re-entry tach. Atharva, you agree with that, or you slam us on this?
No, I agree with you, yes, because this is the narrow complex regular tachycardia. We cannot see the P wave, so the first differential diagnosis is this the SVT?
So after adenosine, the EKG.
Hafiz,
Yeah.
let me comment.
Yeah.
Hafiz, can you hear me?
Yeah.
So
First of all, who is driving? Are you driving or Bobby driving?
I was at a red stop, so I looked at the EKG.
Okay.
So if you look at lead 2 and 3,
yeah,
there is a tiny positive deflection, which probably is not part of the QRS complex. And that's a positive P wave, so it cannot be AV node re-entry. It is probably an atrial tachycardia, some sort. Because if it were AV node re-entry, it should have been negative in 2-3 AVF. It's not, it's positive. So it's some form of atrial tachycardia, probably. It's a supraventricular.
So what happened that this EKG after 12 milligram of adenosine. So now looks like sinus, right?
Yes.
So what do we do now?
Is there Dilip Kumar?
Dilip sir, can you comment on this?
Previous ECG?
Yeah. So I think
the previous tachy ECG.
Tachy ECG, huh? I still go for an AVNRT. Dr. Rafiq, I think his idea was very right. But it looks like a small P wave in V2. but it could be a QRS as well. And V3
But
also.
look, Dr. Kumar, look at this ST segment after the 12 milligram of adenosine, and we did something else. And then the EKG looks normal almost.
Yeah.
So patient's temperature was high and 106, and then troponin was positive. And look at that amphetamine came positive as well. So it's a combination of hyperpyrexia and amphetamine giving this, and then LV function was hyperdynamic. So we did not do anything in terms of revascularization or anything. And we are watching. The patient is still intubated, and we're, Glasgow Coma scale was 3, now a little bit better, but we are cooling the patient first.
Correct. I think, the tachy is still not very clear whether it was a kind of, it looks more of a kind of nodal re-entry tachycardia.
And then the troponin, usually it makes me nervous, but this is the 5th generation troponin assay. So it is actually 643 if you want to compare. So not like 60 or 200. So it's small, but usually, and we did a study that less than 5, it could be non-MI related. Even tachycardia, heat injury can give troponin rise, not necessarily type 1 MI. So a 61-year-old,
yeah. Just one question to Ropik sir regarding the previous patient. Ropik sir?
Because he's driving near the airport.
Okay. Then question to you, Hafiz bhai. If this is the first presentation of ECG of that patient, that is a tachy ECG, after recovery, whether you will recommend ablation for that patient or not? That is the unconscious patient.
So first of all, the tachycardia does not, you said it right, the tachycardia does not explain the unconsciousness. So we'll buy time, patient is in the hospital, there is no rush. Let's treat the patient, see the mentation, and then down the line, whatever you want to do later. So let's get out of this mess with the heat stroke, acidosis, little bit of rhabdo as well, and then troponin injury.
Thank you.
So 61-year-old, while awaiting for a taxi at Caesars Casino, anybody who been Vegas can imagine this scene, became diaphoretic, confused, tremulous, and bystander called emergency service, and patient promptly transported to emergency room. Diabetes, hypertension, COPD. So these are only recent, like from Thursday and Friday. My fellow just gave me this, and this is the EKG. And what happened here, that about the ST segment, V2, V3, and then V4, but V5, V6, okay. And then look at the V1. So they called it anterior ST elevation MI, and then call cardiology. So what do you do now?
So ECG is not visible still.
No, we can
This
see.
is not visible.
Yes, it's visible. It's visible.
We can see it quite all right.
Okay.
Was it Firoz? Maybe your internet connection or what? But
Yes,
what
sir.
you can see,
Internet.
yeah. So what happened that the theme, look at the temperature, 103. So what I'm saying, in Vegas, when we see heat stroke related issues, we don't jump on the STEMI situation. And when we did the echo, the patient with the temperature so high, insensible water loss, relative hypovolemia, the LV is like hyperdynamic. So we tell them, okay, forget about the troponin, cool the patient, and then we'll revisit and then check out the mentation. Sometimes there is confounding factor, and then we buy time, and then we'll decide. I'll give you feedback about these patients, what we do next. And then by so far, look at the troponin. If it is a truly type 1 anterior ST elevation MI, the troponin would be jumping not 1036 means 1.036. So it's very small troponin. It's usually, if we look at the troponin absolute number, the higher the number, more than 50, the differential becomes like 50 means 50,000 in our assay now. Then it becomes very few differential. Bad cardiomyopathy and true ST elevation MI or non-ST elevation MI. You know, injury pattern, sepsis, type 2 hypoxia, COPD, all these are what I call is small troponin or mini troponin. Mini troponin means I call it less than 1 is mini troponin. That means in the new assay, it is less than 1,000. So the last one, 80-year-old female, and found at home, sad, because she was living alone, covered in feces and urine, and this EKG. What happened here, the ER doctor thought that the patient may had a VFib arrest, and this is the EKG after, and therefore the patient should go to the cath lab. And therefore they are twisting our arms. And I tell you, in the US, one of the easy way to get the patient out of the ER is to call ST elevation MI, because we jump and then we take the patient over and then we deal with this and the ER is relieved because the patient is out of the ER. But I tell my fellows that if you are taking or buying the asset, don't buy toxic asset because you'll regret later. So we usually try to evaluate and consult the ICU and then see where is the best place that the patient should go. Is it like a really an cardiac event or something else going on? So this patient's EKG, you know, I see that there is the ST segment depression. There's nothing ST elevation. So that takes the first problem out. We tell the ER that, look, this is significant probably for ischemic changes, but there is no STEMI criteria here. So don't look at the global thing. But if there is a STEMI, like the other two cases, it becomes a problem because you need to convince the ER and the ICU team, look, there is hyperpyrexia, heat injury, heat stroke, as Atharbai pointed out, mental problem, protect the airways, buy time, and we are always with you. But we don't jump to go to the cath lab. But this one was like this. So, and look at this. The patient said that there was no AC in the patient's home, and the temperature recorded was 104, and then tachycardia and the electrolyte imbalance, and then EKG after cooling down came back normal, but the patient is still having this issue with the altered mentation. We are looking for CT imaging, kidney function is bad, but let's see, the story is just unfolding. This is from last night. So, but we did the bedside echo, and again, these patients often are hypovolumic, and the LV is like hyperdynamic with almost like cavity obliteration. We give them fluid. Whether there is any confounding issue like sepsis, we don't know, but that becomes an issue. So these are the things from Las Vegas experience in this summer.
Dr. Hafiz.
Okay, and I have a last case actually. While we are doing this, if you have time, okay, go ahead.
Hello.
Yeah, go ahead.
Atharbai, do you want to make a comment?
Atharbai, you are muted.
Hello.
Yes, we can hear you.
Yeah. Atharbai.
No, actually, no. regarding this ECG, actually, I want to ask you a question, previous ECG.
Yeah. This one.
This one, right. Exactly. I want to know actually whether the STT changes happens only because of the heat stroke, or it needs the underlying coronary disease. That is, without any coronary disease, can it happen or not?
Okay, so that's $1 million question, right? Because what we see that in the heat stroke with the ST elevation, I do not know that the ST elevation can be explained by the coronary disease. It can be explained by myocardial injury pattern. But in an 80-year-old, this ST depression, it makes me worried because it could be type 2 MI. It could be, hypoxia, hypoperfusion related troponin rise and changes and type 2 MI, or it can be just heat stroke. We don't know, but we are collecting these examples because this patient, for example, 80-year-old, if she comes around and mentation good, we're going to do cath if we can to see whether there's an underlying coronary disease. But it's
observation from my side. This patient was found to be, unconscious for a while, and she was covered in feces. And so, could it be possible that patient had a seizure, and during the seizure, after the seizure, we can get some kind of transient ECG changes of ST depression, and then
yes,
this is
of course. But who knows? The electrolyte imbalance can give, hyponatremia can give seizure, and then the patient may have an intracranial event, stroke may be possible, and anything can happen. And we are going to image the brain. There is entity called stroke heart syndrome now. You saw in the JAC that this is called a stroke heart syndrome. Patients with a stroke, a neurological event can give EKG changes without significant coronary disease.
I think we see most often these changes, but considering electrolyte anomalies, we usually see changes confined to T waves or P and PR segment.
Yeah.
This gross ST depression we usually not see. I don't know the experience of others, but we do see this kind of ICP increase.
ST depression we don't see because ST depression is pretty significant if it is horizontal or downsloping, but we see T inversions, we see prolonged QT, in the hypercalcemia we see short QT, and then all the arrhythmias we can see. But so let me share this. After all this is a 60-year-old inpatient coming with chest pain on and off, and then a cough and feels feverish. I tell you, in our hospital's last few days, actually, the COVID patients has gone up. We were like 1 or 2 in the ICU from before, but now suddenly we have a surge. It's approaching 100 on our hospital. It's very alarming. So this patient coming with cough and chest pain. So EKG initially was okay, and then COVID test pending, and then got chest pain in the evening last night, and then this EKG, and then they're inpatient. And then my colleague saying what to do. Should we take to the cath lab or not? And things happen. We get COVID RT-PCR test 4 to 6 hours, but her COVID test was in the lab, but did not get to that lot. So unfortunately, she's waiting for the next lot to get the result. So what we do now?
It looks kind of a ST elevation, a ischemic insult to the patient, and I think patient requires a cardiac cath and angiogram.
So the fellow went there, and fellow is saying the LV function looks preserved.
Yeah, it can happen because it looks like a circumflex involvement, which may feel that you may find not a gross big territory getting involved. Maybe small OM branch or one AVL is ST elevation.
Yeah,
So-
only the one elephant it looks significant.
You may find you
Okay.
some
Or,
pass it as a normal echo, small territory.
okay.
But
Okay, good. So first of all, I did not believe the fellow's echo. I told that I'm not sure that I'm not sure that you are reading it right. It's all bias, right? Because it is a subjective thing. And I said this EKG with the chest pain story, this is a STEMI until proven otherwise. It meets the criteria. But like you, I got little fooled. And I tell you, not completely fooled, but oh yeah. Sorry, I did not assemble it right. I gave you the wrong lineup. Um, so this was the EKG. I mean cath. So I thought that maybe an OM, maybe a diagonal, right? But but I got this. So let me see this. So I actually did not do much, but careful those who are interventionalists. Look at the distal LAD. The distal LAD has some lesion, right?
Yes.
And my fellow was with me. I said, let's look at the free highways first. We'll take look at that later. So you give a lot of nitro and all that. And I generally don't go after those things. And look at that. See that? So we give tons of adenosine, tons, like, I don't know, over 500 to 600 adenosine and restore TIMI3 flow. But still, it's a little bit mesmerizing to me that clearly the EKG was in lead 1 in AVL most. You can go back and then see that there is some changes in the I don't know. It is, I cannot even stretch. I don't think that there is any impressive changes in B1, B2, B3. Dr. Kumar, you agree with that? Because Atharvai or Wadud, the most EKG change in lead 1 in AVL. It's really, and by the way, there is a high grade lesion in RCA. We will fix that later. So I thought that is interesting because sometimes in COVID time, you always try to, and the patient had cough and was saying that she felt feverish. So everybody was like, and seeing infiltrate in the chest X-ray. So what happened, there was little congestion and they're seeing that, and I measured the EDP. EDP was end diastolic pressure was 25. This was heart failure cough. So we gave Lasix and revascularized, she felt better. And this morning she's doing good. So we'll do a stage PCI of the right before discharge on Monday. So COVID time, it's always challenging. Any comment?
The point is you have to take the patient to the cath lab. That's the most important thing with this ECG. And
I think, Wadud, you're absolutely right. What Atharvai mentioned, we need to look at the patient's clinical setting. That's the most important thing. We are clinicians first, and then we look at the EKG, interpret the EKG, and then look at the clinical care in totality of information rather than just jumping by the EKG alone. And that's why the session of this, the name of this session is EKG and Beyond. Basics and Beyond. Look at globally. Any comment?
This is actually the experience we get from day to day, and simple things that can make us or break us clinically. Our judgment may be sometimes put into question. But if we do look at the whole scenario, then actually our judgment comes better. For example, a SNodal dysfunction. Dr. Dilip Kumar is emphasizing repeatedly You have to look at the clinical scenario, the symptom context, and whether the symptoms correlate with the 24-hour Holter finding or other ECG finding. Only then you think about a device therapy. Similarly, for interventional cardiologists like us, it's also important whether I'm going to take the patient into cath lab or not, or I have to think of some other thing that may be actually affecting the ECG, the presentation. This is very important. And everything actually comes at the cost of long experience. Isn't it, Hafiz Bhai? Every day we learn something.
Yeah, but also the judgment comes from experience, but you can share the experience. So this is our forum to share the collective experience. Because if we wait for bad experience to gain judgment, it will not be a good thing. So that's why it's good to share the experience and get the judgment.
Arun, do you want to make a comment about this?
No, I was just lost in between. I had some important calls. So I missed. What did you do to that lady? Sorry. The 82 years old lady.
No, 80-year-old lady, we are still buying time, because she was found in the home with, mixed with urine and feces, so not well kept. Temperature was 104. She got intubated and she was hypovolumic, LV hyperdynamic. We are correcting the electrolytes and then supporting and then making sure there is no sepsis, do a CT imaging, make sure there is no stroke, and then cooling down the patient. And then we'll think about whether to do any angiogram later.
Dr. Dilip Kumar, are you with us?
Yes, sir.
Yeah, I'm actually introducing Dr. Professor Arun Maski. He's a professor at Nepal and our colleague and friend. And actually, a lot of Nepalese students, residents in Nepal actually join this program regularly. And they also contributed. And Arun Maski is also one of our faculties who regularly contributes. And I hope, Arun, have you gone through the whole lecture of Dr. Dilip Kumar while with us?
Yeah, I went to the lecture.
I hope you have enjoyed it.
Yeah,
I really enjoyed it. Athar Bhai, before concluding your comment.
I have one question to Hafiz Bhai. How
Sir.
often do you get patients with LVB after COVID?
Oh, actually, we do get very small number, I must say, but I was looking at this question from the Heart Rhythm Society. One of our residents actually doing a study, like a retrospective chart analysis, and looking at bundle branch block or arrhythmias. And I'll be able to tell you more on that. But I think it is very rare that new left bundle with COVID. That's not
last time last time one lady came to me. She showed ECG 2 months back. After COVID, now she's bringing ECG with the LVB. Her wall motions, everything is fine. So I was going through literature. There are few reported LVB. So that's what the question I was asking.
But we have seen also like a rate-related left bundle with the COVID, bad COVID, but then rate comes down, the LVB is gone. The other situation is bad is when we never had any EKG before. Patient came in with COVID and then also got myocarditis, looks like, or I would say Dr. Narula will be unhappy if I say myocarditis because sometimes you don't see inflammation. So I'm choosing a safer term now, COVID-related cardiomyopathy, because sometimes they get like stunning type. So we don't know what is what. So we call it now COVID-related cardiomyopathy if there is no coronary disease. So COVID-related cardiomyopathy with left bundle, we are afraid that the prognosis may be bad, but we are following them up.
But ejection fraction is normal.
Question to Dr. Kumar. Yeah, Dr. Kumar, we have a question. Like currently, as you are one of the pioneer of the LBB pacing and his bundle pacing, But in the eastern part of the country, there is too much of LBB pacing, and his bundle without EP machine, without proper EP settings. Do you still believe this LBB which is going on, is it true LBB or high septal? Because what we have seen in many ECGs, people are saying narrow QRS again can give a good idea of LBB. But we see that the ECG which is coming, which is again narrow QRS, but the pattern is high septal. So can you comment on that? Can you give a message to the entire group?
This is like, in fact, it's very true observation. We see a lot of operators doing and getting satisfied with a little narrow QRS, narrow looking QRS, but still the features and characteristic of left bundle pacing is not met. So it's all, but it is not like that we can't do without a kind of ECG. If you get a 12 lead, good 12 lead ECG projection,
right,
definitely do a left bundle pattern with patients with full criteria. You can appreciate our, QS and RV pattern V1 coming in, and maybe a QRS in these cases. You may not, you will be able to see a LB80, and you may not go for a, other characteristic to look at. I can't see a left bundle potential, but other characteristic you can see. And one observation from my side, like Dr. Arun Maski asked, one of our case report is under review in journal, where got a patient. It was very interesting. I got a call from emergency department. The patient had a history of syncope, and we saw the ECG. It was kind of 45 to 50 heart rate with P waves rising from near coronary sinus. So it was a 2-3 inverted, P wave inverted in 2-3 AVF. So it was kind of a wandering pacemaker sort of thing, we thought. And there were some early coupled VPCs were there. So it gave us a little alarm that patient had a 2 history of syncope. He fell down bathroom. He came here. So what would be things happening in the patient? Once we thought we'll do a echo, we'll do a test, blood test, and then we'll come to see the patient, and we'll also look at monitor what is happening. As soon as I went up in my chamber, I got a call again that patient again had a episode of pulseless kind of episode. He and then he came back before they could see a rhythm. He was about to be given a ECG, cables, and they couldn't record what happened. So we were stuck at the same time. The patient was transferred to CCU, and patient developed VF episodes, and majority of the time VF was self-sustaining. So early coupled VPC is triggering to VF. So after 1 hour of these, self-terminating VFs, now we required kind of shocking these patients. So we had given 2 shocks on amidron, on xylocard infusion. Still it was coming up. At that time, we had no COVID report. So we took this patient, considering as a ACS.
Dr. Kumar, was it like a episodes of torsade?
No, yeah, torsade. Yeah, early, just VF, not torsade, just VF. It was early coupling VPC. Okay, and then we took the patient to cath lab, and we found 2 vessel disease, LAD of 85%, circumflex of 90% disease. So, but it was not very clear that how can this flowing TB3 flow lead to such kind of VF. So we spoke to relatives, we got some disease, but I don't think fixing this is going to clear off the patient of VF. Let's buy some time. And by the evening, the patient had 7 with lactic acid of 7.1 and a pH of 7.19. We got the COVID report, and it was positive. And then we asked the patient, we need the patient to be intubated, and but there is no other option. So the relatives told that he is COVID positive with VF. I don't want to do anything, and let it be a DNR. Do not resuscitate this patient. So it was a very, very bad experience. Then in last resort, what we did was we started the patient on IV methylprednisolone. And believe me, the patient VF storm disappeared after the first dose of methylprednisolone. Next day, the patient was sitting fine with normal ABG and everything. He never had VF on VPCs after that. And patient is still doing well. It was a COVID kind of myocarditis, what we call COVID-related cardiomyopathy, you can say. And this is, we have got a review, and I think it is going to be published in Indian Heart Journal. So we do this in case of VF storm, myocarditis, arrhythmias. can happen in COVID, and we have seen that.
Dr. Dilip, recently I got a patient, one of my friend's mother. She developed atrial flutter and related heart failure, and just a slight fever for 1 day fever. And we found out she is COVID positive. She reverted with only amiodarone, and now she is home, quite all right. She had coronaritis, minor coronaritis. We had done the CAG a few years ago, and was normal LV function. But the whole thing seems to be related to COVID. So what types of arrhythmia you are getting in India? COVID related.
Obviously, atrial fibrillation is seen in all kind of infections. So in COVID also, it's not spared. But ventricular arrhythmias are very common, and autonomic dysfunction, extremes of sinus rates. We see up to 3 months of COVID. We have seen these patients having heart rate of 40, 45, or sometimes going to 130, 120. So autonomic dysfunction we are seeing in these patients.
A lot of patients. Atar Bhai, would you say something before conclusion?
Yes, Jodhbhai, thank you very much. And 2 great, brilliant talks today. Finally, Dr. Chaudhary Hafizul Hasan, we always enjoy his lecture. Actually, he shows some ECGs that is exceptional and sometimes gives some clinical clues. We always enjoy Chaudhary's lecture and ECGs. Thank you very much, Chaudhary, and congratulations for showing some excellent ECG and the clinical scenario today. And finally, I must congratulate Dr. Dilip Kumar. Dilip Kumar is very popular in Bangladesh. He is a friend of Bangladesh, I think. He has visited Bangladesh several times. He is a great teacher. Actually, he comes Bangladesh several times for training in the Medtronic, that is the training center. And he also, I personally have got training under him. Actually, he's a trainer for the conduction system pacing. I always take some advices regarding the conduction system pacing. So he's a renowned cardiologist, renowned electrophysiologist. He's a good man and a great teacher. He's a friend of Bangladesh. And we enjoyed his whole lecture, exceptional lecture today. Dr. Dilip Kumar, thank you very much for staying with us and giving some. And we always look forward to have some such type of lecture again in different times.
It was great to meet you, Dr. Kumar.
Pleasure is all mine, sir. Thank you, sir.
Dr. Dilip, in this forum, we have rather an informal way. It's a sort of friendly tutorial for every one of us. And all of us enjoys each other's company, have a good laugh, and learn a little bit more each and every week. That's the way we are trying to do this whole thing. Devasrito, you have been to our program many times. I hope you agree with me.
Sir, absolutely. This is one of the forum I tell every students of in eastern part of the country, those who are students, I tell them, I request them to be a part of this program. It is amazing educational program. And I requested Dr. Dilip Kumar for that matter. Anything in this entire 2-3 hour session, if we learn 2 or 3 things, that will help entire student group for their future. That's for sure. From Dr. Kumar, from Dr. Rafiq, from you and all the senior cardiologists. So it's a very, very good learning program which you all developed in an informal manner, and we learn many, many things. And thanks, kudos to all of you taking your busy schedule out and helping your student. That's more important to develop the new student in the new therapy area. Thank you so much, doctor.
Atar Bhai, please conclude.
So we can conclude the session today. It is too late. In next Sunday, our speaker will be Dr. Abhishek Deshmukh. And at the same time, Dr. Chaudhary Hasan and Rafiq sir will be with us. And we will be happy to see Dr. Dilip Kumar if you have got any time. So Dr. Abhishek Deshmukh is the next Sunday. And Arun Maski, welcome. And Arun Maski, we always appreciate your presence, and you always accompanied by your several students. So Arun Maski is our great friend, and we always happy to see Arun Maski in the screen. Arun Maski, thank you too much again.
Yeah, Dr. Abhishek also told that get ready with all the questions, many questions, and he will be responding from Mayo Clinic on next week.
Thank you, Devasrito. So Aditbhai, you can conclude the session tonight.
Yeah, please. I hope everybody has enjoyed to this program, and I do hope we'll learn together and enjoy the session together again and again. Every week at 9:30 Bangladesh time at night, every Sunday. And thank you and good night, everybody.
Good night.
Good
Dr.
night.
Dilip,
Thank you, Chaudhary.
really, we are thankful to you.
Sir.